The 2-day blizzard that your town endured has just ended. The area received about a foot of snow, but it's now sunny out. You and your partner are assigned to the report of chest pain at a little house in the southeast corner of your jurisdiction. When you arrive, the residential street is unplowed, and it doesn't look like your ambulance will be able to make it to the patient's driveway. So you park on the main street and walk 4 houses up to the address with your gear. The patient's house's driveway is half shoveled, so you have an idea what's going on before you even enter the house. Inside, you find a 60-year-old male patient complaining of 10 out of 10 chest pain that he describes as squeezing. The pain radiates to his left shoulder, and he states that it feels like he isn't getting enough air. The pain started about an hour ago while he was, wait for it, shoveling snow. He's warm, pink, and dry. His wife reports a history of hypertension and hyperlipidemia, for which he takes lisinopril and a statin that they can't remember the name of. The patient had something he describes as a heart attack 15 years ago, but this pain is not similar to that episode. As he remembers it, the prior episode was much less severe compared to now. The patient's blood pressure is 110/70, heart rate of 40, respiratory rate of 20, and a pulse ox reading of 98% on room air. You ask your partner to place the patient on the monitor and run a 12-lead EKG. Pause to take a look at this. What's your interpretation of this EKG? What's your plan? Did you even pause? You did, right? Look at it. Look at it! I'm Angry Bill, and this is Pre-Hospital Wisdom. We understand that medicine is medicine, but pre-hospital providers have special skills, knowledge, and culture that other providers don't have. Let's raise the bar here a little. This is a second-degree AV block with fixed 2-to-1 conduction. The atrial rate's approximately 80, and the ventricular rate's approximately 40. The pure interval is normal when it conducts at 0.12, and the QRS duration is narrow, I'd say about 0.08. The axis is normal, and there's no clear signs of chamber enlargement. There are Q waves from V1 through V4, the zone of transition's late, and there's obvious ST elevation in the inferior leads with ST depression everywhere else. The T waves are pretty large in comparison to the QRSs. This brings us back to what I wanted to talk about, second-degree AV blocks. There are 3 kinds of second-degree AV blocks. There are type 1, Winky box, type 2, and 2-to-1 conductors. All have the same issue going on, a P wave that doesn't cause a QRS when it should. This means that the P wave fell at a time when the ventricles can be assumed to be repolarized. The P wave falls well after the T wave. This is why blocked PACs, for example, aren't second-degree AV blocks. PACs can fall so prematurely that the ventricles are not yet repolarized. This isn't the case with second-degree AV blocks. A second-degree AV block type 1 has a progressively lengthening PR interval, a non-conducted P wave, making it a second-degree AV block, and then the PR interval pattern resets. The QRS duration is usually narrow, and if rate assistance is needed, the rhythm usually responds well to atropine. Type 1s are more commonly associated with inferior MIs, but the MI is not specifically necessary. A second-degree AV block type 2 is an extremely rare rhythm. These have consistent PR intervals with occasional non-conducted P waves. In contrast to type 1s, a type 2 can have multiple non-conducted P waves in a row. That would be called a high-grade AV block. The damage to the myocardium that results in this rhythm is more extensive, so the QRS duration is almost always wide. Type 2s do not usually respond to atropine, and pacing is almost always required. Type 2s are more commonly associated with anterior MIs, and can progress to complete heart blocks or ventricular asystole. That's no QRS, just P waves marching along. These are dangerous rhythms. So you can see that the difference between type 1 and type 2 is whether the PR interval is lengthening or constant. Thus, you need at least 2 PR intervals consecutively to compare before a dropped beat. You need to compare a PR interval A to a PR interval B. You have to compare the first PR interval to the second PR interval. You can't compare 2 first PR intervals. You can't compare 2 PR intervals that fall immediately after the non-conducted P wave. The non-conducted P wave can reset the cycle, so you need the comparison PR intervals to be between 2 dropped Ps. You need at least a 3-to-2 conduction to be going on, but 4-to-3 or 20-to-19 or whatever works just as well. However it works, you have to compare the first PR interval after the non-conducted P to the second PR interval. You can't compare 2 first PR intervals. What if you have 2-to-1 conduction? You can't technically tell if it's a type 1 or a type 2. So you should call it what you know it is, second-degree AV block with fixed 2-to-1 conduction. Look at the labeled EKG now with the P waves marked out. 2-to-1 atrial ventricular conduction. We can surmise that it's probably a type 1 with 2-to-1 conduction going on for a couple reasons. First, there's an inferior MI, which is more commonly associated with type 1s. Second, the QRS duration is narrow, which would be more unusual in a type 2. But I'm using the word usually, so there's no way to be technically positive 100% sure. The Q waves in late transition and the V leads are probably an old anterior MI, maybe the one from 15 years ago, but again, there's no way for us to be positive sitting in a dude's living room. So what's your plan for this gentleman? Hopefully it involves titrating his oxygen delivery to maintain saturations as needed. He doesn't need that right now. Give him aspirin and fentanyl with rapid transport and early hospital notification. 2 lines will help you look cool. Toss some combi pads on him. Is this a STEMI alert? I should say so. This fellow's almost certainly having an acute inferior, likely inferior posterior MI. Here's another question for you. Would you give him nitroglycerin? Well, that's a discussion for another day. Next week, if all goes according to plan. This post is long enough as it is. Let me know your nitro answer in the comments, as well as letting me know if there's anything I missed here or if you would do something differently. One of the most helpful things you can do is share this content with someone you know. Click here for another video or click over here on this side for the channel page and all the videos. Subscribe is below. I think it's down somewhere around here. Click that and the bell to make sure you don't miss any nitroglycerin answers. I'm Angry Bill. This is Pre-Hospital Wisdom. And until next time, don't forget EMS Rule 2.